Hello, welcome to Fertility Factor Fiction. I am your host, Dr. Rahi Victory, and tonight we are going to learn about whether or not your progesterone level should be higher if you're doing a frozen embryo transfer and you have endometriosis. Certainly an interesting topic. Thank you all for joining us, and we're just going to take a minute to chit-chat while everybody jumps on. If you didn't hear about it already, we are very pleased to have the support of the Ministry of Health of Ontario for getting IVF funding. So we are now able to provide patients with funding for their IVF cycle if you qualify. Some people have been asking us what the qualifications are. So we're going to add that to our revised website as soon as that's available. But essentially, you have to be a resident of Ontario holding valid Ontario health card, and the female has to be less than 43 years of age, or the recipient of the embryos needs to be less than 43 years of age. And as long as you qualify that way, that's fine. Each clinic then has its own kind of sub-qualifications, and we have ours as well, but we take it on a case-by-case basis to be sure. So if you are in need of IVF, you don't have to be from this area. You can be from anywhere, but we get lots of people that have been on multiple different wait lists, and you're welcome to join ours as well. So hopefully that's going to help a lot of families. We have enough funding for about 135 people per year. We were definitely hoping for more. That did not pan out, but this is a good start, and hopefully we can help a lot of families this way as we move forward. So very, very excited about this, very pleased. Huge thanks to the Minister of Health and to the Premier of Ontario, both of whom were instrumental in making this happen. So very, very pleased and appreciative. With no further ado, we're going to get right into it. So this is from a study in Reproductive Biomedicine Online, and it's coming out. It's not published yet. It's still in the uncorrected proof version. And so essentially what they wanted to do was see if the progesterone levels measured during your preparation for your frozen embryo transfer make a difference in terms of your frozen embryo transfer success rates, in terms, of live birth and clinical pregnancy and miscarriage rates and all that stuff. So the reason for this requires a little bit of explanation. So let's go through some basic information that you need to know. What is endometriosis? Endometriosis is when the cells from inside your uterus actually jump and go into your pelvis or any other place. And so it is what we call ectopic or out of place location of cells from the inside of the uterus to somewhere outside of the uterus. Why is it a problem? Well, it's a problem because patients with endometriosis have a much higher risk of immune activation. And because their immune system is overactive, it can cause scarring, it can cause pain, it can make it harder to just have sex. It can cause a lot of inflammation leading to immunological reasons why your fertility actually just isn't functioning properly, because your immune system can be interfering. At least that's the theory behind some of it. And then, of course, there's the whole physical aspect of it, where it can cause scarring, damage, blockage of your fallopian tubes, cysts in your ovaries, reduction of your AMH and your ovarian reserve. So that's kind of the what is it and the how it affects people. How many people are affected? They say up to 25% of women will have endometriosis, possibly even more in a population of fertility patients. So again, very prevalent, very common. So what's happening at the microscopic level? Well, we know that patients with endometriosis have altered receptivity in their endometrium, and that they have altered receptivity because the progesterone receptors don't work the same way as in somebody that does not have endometriosis. So the amount of estrogen and progesterone that's going through your system doesn't necessarily translate into the same outcome when you have endometriosis versus when you don't have endometriosis. So in theory, what these authors thought about was that based on the basic science information that was available, it's very likely that patients that have endometriosis require more progesterone because they're not as receptive to the progesterone. The receptors aren't working properly. They're not accepting the progesterone and processing it properly. What happens if we give them more? So interestingly, the background to this is really important. There are studies that definitely show that if you don't have enough progesterone, you're actually going to fail. And that's been pretty clear for a long time, which is why we poke and prod all of you with either vaginal progesterone or progesterone in oil or both. So that's been known for forever, like pretty much forever in the fertility world. And we've been doing that for a very long time. So because of that, we all are using progesterone or progesterones to help support your pregnancy. But then there are studies that say there may be too high a level as well. And there's argument as to what that level is. Some people say somewhere in the mid 60s for nanomoles per liter. Some people say under 100 for nanomoles per liter. Those are the Canadian units. 100 translates to roughly 30 something in the American nanograms per mil. So the question here was, what happens if we go above that threshold? What if we go over 100 and see what happens there? So this is how they got to this study. Tarek and I are just going to share our screen once that's available. I'm going to jump out of the home screen in a second. Okay. So, so here's the paper. Is it up? So it says endometriosis patients benefit from high serum progesterone and hormone replacement therapy, frozen embryo transfer cycles, a cohort study. So interesting just from the title. So number one, it tells you off the hop, you're going to do better if you have higher progesterone levels. So the story is out there already. You guys can start asking questions about that. Number two, this is in hormone replacement therapy cycles. So keep in mind that virtually everyone out there hopefully now recognizes that the traditional frozen embryo transfer approach, where you give people estrogen and then you give them progesterone, is a terrible idea, resulting in far less success than the alternatives, which are natural or letrozole, which is even better. So this doesn't necessarily apply to what everybody is doing. Now it might, and you may be able to carry this on, but it also may not. The other part of it is that it's a cohort study. So this was not a randomized controlled trial. So they followed people and then monitored what their progesterone levels were like, and then they reported it. That's great, but it's not as good as saying, hey, this group with endo, just take this much progesterone, and this group with endo, you take that much progesterone, and let's see what the actual differences are. And we're going to randomly assign you so we don't get to be picky and send the better patients to one group and the worst patients to the other. So it's missing a few kind of finesse to it there, but it's at least some information and it's kind of valuable for what they've done. So total, they had 262 frozen embryo transfers from 179 patients. About 2/3 of them got pregnant after one try. About 1/3 of them needed a second or more tries. So some other interesting tidbits to how they did it, because I disagree with a lot of this methodology. And if you watch the show, you'll know why we disagree with it. So all patients were pre-treated with 6 weeks of oral contraceptive pills. Not unreasonable if you have endometriosis. Why? Because we know for sure that the birth control pill is reasonable at suppressing endometriosis. And if you can suppress the endometriosis, that's probably going to be helpful. Hopefully, a lot of you watched my reel on Instagram where I said that that lunatic that was claiming that the birth control pill causes depression and suicide was wrong. That is categorically incorrect. There is good systematic review evidence demonstrating that the birth control pill does not cause depression or suicide, especially amongst adolescents. So I took that data and think that that's important. But in terms of this specific area, there is benefit to taking the birth control pill because it will quiet the endometriosis. However, if you follow a little further into it, and I'll blow it up for you here, they then had 5 days washout and then did 6 milligrams of oral estradiol valerate. And that was done once daily. So they're giving people the full estrogen exposure. The whole point of trying to suppress people's endo is to avoid exposing them to estrogen. So why would you give these people estrogen? I don't know. doesn't make a lot of sense to me, but this is the old protocol. That's what they do in hormone replacement therapy cycles. So I get why. An ultrasound was done after 12 to 19 days. It seems like a really long time, but nevertheless, they let it go for that long. And once they got to an endometrial thickness of 7 millimeters, they said, okay, we're going to start the progesterone. The progesterone was done with crinone, 90 milligrams every 12 hours, administered vaginally. And then on the 4th day, they also started using injectable progesterone. This is really cool because this is a European study. It's actually out of Denmark, where I just was on the weekend. And they don't use progesterone in oil in Europe. So this was kind of shocking to me, and I did appreciate that part of it. And then the rest of it is just what they did afterwards. Not quite as important, but bottom line is that was kind of how things were done. They did do a progesterone level after they had patients on the progesterone in oil and the vaginal. Okay, so let's go over to the data. And this is actually going to be quick tonight. We're going to leave you guys lots of time to ask questions about anything that you like. So I'll blow this up. Actually, maybe if I go this way, because then I can blow it up a bit bigger. Okay, can you see that? Yep. Okay, so as I said, 262 frozen embryo transfers and 179 patients. So obviously the serum progesterone levels in the progesterone less than 118 group was much lower, on average 79.8. In the over 118 group, it was 150. So way, way higher. So they used this arbitrary cutoff. They must have developed a statistical curve, what's called an ROC curve. They found the cutoff point, it must have been 118. And then they used that 118 to then go back and examine the data to see how people did. So obviously in the greater than 118 group, it was really high. Like I personally would lose my mind if my patient's progesterone was 150, because that's a high progesterone level. That's like getting to birth control progesterone levels. So this is a lot. Whereas in the other group, it's kind of our target. That's really where we're hoping to be, in that 60, 70, 80 range. So that was a nice level there. Age, no difference. Body mass index, no difference. Keep in mind, these are relatively thin or borderline thin people. So most of them are pretty healthy. They did have some smokers, but thankfully not many. Usually European studies, everybody's smoking, so that was good. No other statistically significant differences till you get down to day of vitrification. So in the progesterone less than 118, 71% of the patients had day 5 blastocysts, 29% were in the greater than 118 for day 5 blastocysts. With the day 6 blastocysts, 51% of those patients had a less than 118, 49% had a greater than 118. Now that also may be related to the duration of exposure, but they actually made everybody transfer after 5 days, whereas for a day 6 embryo, we actually recommend you put it in after 6 completed days of progesterone. So again, another little glitch in the study there. Okay, where's the most important part? It's the part I've highlighted for you at the bottom, right? So the pregnancy rate per embryo transfer, they had a total of 60%, and 56% were, or I guess they had an average of 60%. So 56% were in the progesterone less than 118 group, and 69% were in the group that were over 118. So the group that was over 118 had this 13% higher pregnancy rate, and that per embryo transfer, and that's a lot. And all of the patients in this study had been confirmed to have endometriosis by surgery. So this is a very kind of valuable data set to look at. Implantation rate, 40% in the less than 118 versus 52% in the over 118. That's a big number. I mean, when you're 12% higher, that's getting close to almost 30% of the lower group. So you're getting a 30% boost in the number of pregnancies that you're achieving. That's a lot. So that's something that's very, very significant to consider. Live birth rate, which is obviously the holy grail, 34% in the group that's 118, but it's 51% in the group that's over 118. Now, the reason this is so critical is we know that endo patients get their success rates cut in half usually. In this study, they're actually almost normalizing your success rates. I mean, obviously, we have a higher rate than 51% for live birth, but these are really, really good numbers. Like, you don't normally find studies where 51% of the patients in the study were able to actually deliver a live baby when they had endometriosis. So this is suggesting that when you get these higher levels of progesterone, even as high as 150, you can actually increase the chances that you're going to achieve a live birth. And please remember, and look at this carefully, the units are really important. Whoops. We are talking about nanomoles per liter. You can see it right there. We are not talking about nanograms per mil. If you had 118 nanograms per mil, you'd probably be asleep because it would work like a sedative. They then went into it a little bit more in detail, and they wanted to evaluate what factors affected this. So you do that in something called a logistic regression analysis. So they, put in all of the confounding variables. They adjusted for body mass index, age, blastocyst age, which is day 5 or day 6, blastocyst quality, which is hugely important, and even number of blastocysts transferred. So that's also important. It's particularly important because if they didn't standardize it to just one embryo, that would also alter where the results are coming from. So this helps with that. So the group that had serum progesterone concentration over 118 had a 110% increase in the success rates after they controlled for all the confounding variables. That's what 2.10 means. So over double the success rate for live birth. This is huge, 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 right? We can't get that with anything else in an endo patient. So is this a game changer? Yes, this is a game changer. We will be adjusting our progesterone levels in our endo patients to go higher. Did the body mass index make a difference? No, it did not. Age? Yes. So the older you are, the lower your chances were of success by about 7%. Day 6 blastocysts did not have a difference compared to day 5 blastocysts. So that's also really interesting here. The blastocyst score did not make a difference. And the number of blastocysts transferred, whether it was the double or the single, it actually didn't make a difference either. So why is this important? This is important because I've never seen any study anywhere that can demonstrate a 100% increase in your live birth rate with IVF for anything we do with endometriosis. Our Lupron and Letrozole protocol won't get you a 100% increase. Doing surgical treatment won't get you a 100% increase. Taking all the supplements that we use will not get you a 100% increase. But this little tiny tweak of giving you a little more progesterone may be the key to success. And for me, that's huge. Would I like to see this done in a better trial? Yes. Am I willing to try and take a look at that and see if we can do that here? Definitely yes. But ultimately, this is super important as at least a starting point to see if this data can bear out and help us to help those patients with endo. So if you're suffering with endo, if that's part of your fertility journey and you need something done, you need to talk to your doctor about making sure that they are maintaining the right level of progesterone for you. So is it a fact or a fiction that patients with endo need a higher dose of progesterone for their frozen embryo transfer? If you're doing a hormone replacement therapy cycle, yes, it is a fact. It appears that you do. You can get nearly double the success rate. So thank you for joining us for Fertility Fact or Fiction. We always appreciate you guys being here. Make sure you click the like button and subscribe if you're on YouTube, or follow us on Instagram and Facebook and Twitter. And now we're going to take your questions live.
Right.
I'm always ready, man. Should I shut this off?
That's all good.
You're off over there.
Yeah.
Okay.
Hi, Dr. Victor.
I'll go to the draw program.
Is it okay to do back-to-back cycles, retrieval and then transfer, retrieval cycle, is antagonist with esterase priming, FSH, is 300 gonal F, 150 menopure, which I know you think is too high. My partner will be taking Omnitrope as well. Transfer would be controlled transfer. Our client doesn't want to do the transfer in the following cycle.
Okay, so you're taking a huge dose of medication, which we try and stay away from. So I would recommend you not take that full dose. But if you're going to use that, and we do go that high sometimes, then you should be doing 225 gonal, 225 menopure. The ratio is important, and you'll do better with the equivalent ratio. As far as doing the retrieval and then the transfer, it depends on a lot of factors and how many eggs you make. But if your estrogen level gets high enough, it is very clear that it is detrimental to the outcomes of the IVF cycle and to the outcomes of the pregnancy as well. It is safer to undergo a frozen embryo transfer. So we would not advocate for exactly the protocol you're taking. I would say that it's much better to do your transfer in a subsequent cycle with a frozen embryo. But every case is different. If you only end up with one embryo, yeah, of course, go ahead and transfer. But that would also necessitate that you ended up with one embryo because you only made 1 or 2 eggs. If you're making 3, 6, 8, 10 eggs, your estrogen levels are so high, your endometrium is supercharged. That's not a good endometrium to transfer embryos into.
Hi, Dr. B&T.
Hello.
Just had my egg retrieval and got 11 embryos biopsied and frozen.
Wow.
We are
Congrats.
doing PGTA because of recurrent loss.
Yeah.
What can I do now until my transfer to boost my odds for success?
Eat healthy, exercise every day, meditate, do yoga. There are studies that show that yoga is beneficial. Acupuncture may help you as well. Make sure your vitamin levels are appropriate. So vitamin D, iron, you want to make sure of B12, your omega-3 fish oils. Start taking melatonin, and then just get your body in the best health you can. And have lots of sex because it primes your uterus when he ejaculates inside you for the embryo transfer. So that's reasonable as well. I actually like this tea. It's good tea. Yeah.
How do you prep the lining for someone with endo without estrogen?
Letrozole. You just use letrozole or natural cycle, but we use letrozole, which makes even more sense in an endo patient than natural because it keeps your estrogen levels low. So definitely use letrozole. That's the way to do it. Do not take estrogen. It's maniacal to me that any program would consider giving someone with endo estrogen unless you absolutely have to. If you can avoid it, avoid it.
So this one's a little bit special.
Okay.
Because they said, hi, Dr. V and T, but the T has a hug emoji next to it. Oh. Now, it might be for both of us, but I'm going to say...
You're taking it for you. Okay.
Yeah. And she's also from New Orleans.
Oh, hey, we haven't had someone from New Orleans. Yeah. Hello, New Orleans. I hope you guys are safe. They didn't get bad or quite as bad as Florida did. So, yeah, fire away. What's the question?
I live in New Orleans and go out of state for fertility care.
Oh, okay.
I signed up for a consult with you.
Amazing.
When do you require patients to come to Canada for stims and retrieval?
Just for retrieval and transfer. You can get your stim monitored in your hometown or home state at any fertility clinic that knows what they're doing. So we arrange that all the time. We have more and more patients coming from the States all the time with really excellent results. So that's really easy to do and no problem. I just had a patient who's definitely one of my favorites who is from New York. And they previously had a not so great outcome. And they came to us and we got, I think, close to triple the number of eggs they got before. So, not an issue. We're more than happy to help you out if you're from the US. The US tends to be very kind of rigid in my experience with really kind of the same cookie cutter approach to things in many cases. And we're not like that at all. I customize for every single patient. And more these days, every day, at least 2 or 3 people contact us online to say, can we do a consult with you? Because we want a customized protocol for ourselves. And we do that all the time and get a lot more eggs and often better quality embryos as well. So twice is the answer, my long-winded answer.
They said, I thought you couldn't have favorites.
Oh, well, I said one of my favorites. We're allowed to have some favorites. I'm not allowed to say who they are, but I can say that I have some favorites. Yeah. I have a favorite child. Both my boys know my daughter is my favorite. Hi, Jenny. I love you. Yeah.
Hello, Dr. TV. Straight
TV.
TV.
There you go. Okay.
And
I love the fact that I'm last.
that's right. That's right. T preceded V. Putting it out there.
Yep.
Would you recommend a cyst check before a donor FET?
Cis SIS.
SYST.
Before a donor FET.
Yeah, on birth control for scheduling. My doctor says it's not required. My last SIS was April and I was clear. Thank you.
If by cyst you mean sonohysterogram and you already had one in April, no.
It must be, right?
Yeah, no, I would not recommend you do that again. Once that close is fine. I mean, we'd normally go 6 months and you're right on the border, but if it was totally clear and you don't have any risk for anything, no. Now, granted, if you only have one embryo, sure, it's harmless to do it again. But if you have more than one embryo and in fact have several embryos, which you should if you did donor egg or donor embryo, then I wouldn't worry about it. Good question.
I was pretty happy with the Dr. TV.
Yeah, you like the Dr. TV.
Yeah. Replying to Jenna Marie.
Okay.
Hi, Dr. Victory. 1, if a woman has transferred good quality embryos that have not been tested a few times, but they won't implant, lining is good, levels are good, etc.
Yeah.
What additional test procedures would you recommend? 2, is acupuncture and chiropractic safe during early pregnancy?
Acupuncture is safe. Chiropractic is safe as long as they're not trying to snap you in half. So it has to be fairly gentle chiropractic, not the traumatic, like put you on those boards where the board snaps and it makes you feel like something's happening.
There's a lot of reels about like chiropractor stuff on TikTok.
I watched a funny one today
They keep dying.
where they were doing her foot and then she wore her shoe sideways and walked it. So it looked like her foot was broken. So the answer to the second question is that essentially chiropractic and acupuncture and stuff like that is safe. The first part again was
if a woman has transferred a few times.
Oh, yeah. What test would I do? Yeah. Okay, what test would I do? So those are the kinds of cases where you really need to consult with me because I'll spend an hour with you and go through each and every detail of what's going on. So tests that we would commonly do are recurrent implantation failure tests or recurrent pregnancy loss tests. So sperm DNA fragmentation and a semen analysis for your partner, chromosomes for both of you. We would look at vitamin levels in you, thyroid and thyroid antibody levels in you, all of your other hormones, including prolactin, or at least all of the other important hormones, including prolactin. We would evaluate your general health. What's your BMI? Are you a smoker, drinker, drug user? We would probably look at a thrombophilia screen, and we would do fertility testing for DNA of bacteria and viruses in your uterus, as well as a reproductive immunology panel. So all of those are things that we would take a crack at and take a look at.
Hi, Dr. V and T.
Yep.
I'm 43.
Okay.
Did 2 egg retrievals at 42, resulting in 3 PGT tested embryos through sperm donor.
Awesome.
2 transfers failed.
Oh.
Will be coming to you for my 3rd.
Okay.
Would I still be a good candidate to go for one more round of egg retrieval? AMH at 41 was 2.58. Thank you for always answering questions here and through DM.
Is that nanograms per mil or just
unit per liter? Not shared.
Oh, okay. So if you're, I'm going to guess that it was nanograms per mil. The reason I'm guessing that is 2.4 is very low if it was picomoles per liter. And I'd be actually surprised if in just two previous cycles, you were able to get 3 PGT normal embryos. So if your AMH is that high, yes, I would actually recommend you make more embryos. And we definitely need to do all of the testing I just mentioned for the previous person that was asking the question to figure out why you failed 2 PGT normal embryo transfers. So there's a lot of testing to do before we jump into the whole transfer protocol. That's really critical. And I should probably mention sometimes that's surgery to see if there's endo inside there. So those are some of the things that we will look at in addition to all the other tests that we offer people.
I'm going to give a warning to everybody.
Okay.
This is one of our most busiest shows.
Oh, okay.
So
it's a busy show.
Come in right away.
Okay. And guys, if you're asking questions, don't leave the show because I do get to them, but there's a bit of a lag because we got to go in sequence here.
I really like my first consultation with you today.
Oh, fantastic. That's very nice.
Yeah, awesome.
I'll have to figure out who that was.
I'll tell you after.
Yeah.
What does this mean for the current wait lists? I think this was referring to.
Well, it'll drastically reduce the timeline because we were thinking that it was going to be like 5 years before we get to some of our patients, but we think we'll be through our wait list on a yearly basis. So hopefully it'll only be 1 year maximum that you're waiting to get your IVF cycle.
Dr. V&T, thank you for everything.
Oh, thank you.
For natural cycles, fresh transfers.
Yeah.
Do we need vaginal and injections for progesterone or only one?
Yeah, I still use both, but we need lower doses because the corpus luteum from your egg is going to produce some progesterone as well if it's going in fresh. So we can drop the doses a lot, but I still use both. Creature of habit that way.
Novarel.
Yeah.
Or Pregnil as better trigger shot.
Theoretically, it shouldn't make a difference. I am kind of partial to Pregnil only because I've used it for so long and I like it. I don't have any experience with Novarel. So just, being honest about that. But I am not beholden to one particular company. In fact, we try and equally distribute our usage amongst all the different companies. I do have my particular protocols that I like, and I have my reasons for that. But for your trigger, we always use Pregnil. I've never even tried Novarel before.
I actually always use Novarel.
You always
Full disclosure.
Full disclosure. Tarek says he always uses Novarel. Yeah.
Thanks for all that you do, Dr. B&T.
Our pleasure.
What investigations would you recommend for a 35-year-old male with a history of 3 years untreated chlamydia at age 20? Also, history of HPV infection.
Investigations? I mean, that's pretty easy. I would do your STD screen again. I would get a urine for chlamydia, gonorrhea. We would do blood sexually transmitted disease screens. You need a semen analysis, probably a DNA frag. And then if you really want to get fancy, Fertility can actually test for the presence of bacteria and viruses inside your sperm, which is super cool. And I don't know anyone else that does that. Having said that, we have no idea if that's of any value whatsoever, but it's cool to figure out. If you don't mind and you want to find out everything about yourself, that's a very neat test. What value does it have? Well, we'd probably give you more antibiotics and retest you until whatever it was cleared. Because I can't imagine it's good to have any bacteria inside your sperm, but it is not something anybody has any publications on that I'm aware of yet. So very cool data, but we don't know anything about what it means.
We have somebody that's very politically correct here.
Okay.
Hello, Dr. Victory.
Yeah.
NT. I'm sure. I like TV.
You lost the Dr. TV.
Yeah, I got demoted here.
Yeah.
Thank you for the tips.
Okay.
So far, I'm 5 weeks today.
Oh, congratulations.
With euploid embryos.
Okay.
Just turned 41.
Okay.
Fairly healthy.
Yep.
Are there any success on the first try in experience for my age group?
Is this reasonable for your age group?
Yeah, is it gonna do it?
Yeah. I mean, the chances of miscarriage with a euploid embryo is low. So as long as there's nothing else wrong, you should have a great, pregnancy, hopefully. Make sure you stay on your progesterone would be my advice. Make sure you're taking lots of vitamins. And yeah, no smoking, no drinking, no drug use. We recommend aspirin. In your case, we would definitely recommend aspirin. So there are some things you can do to maximize your safety and chances of a successful outcome. But yeah, I mean, you should do very, very well. And congratulations. Yay.
Round of applause.
Round of applause. We need like a synthesizer where you can hit, laughter. We should get one of those. That'd be fun.
I like the idea.
Yeah, that'd be fun.
Does severity of endo stage 1 versus stage 4 mean you need even more progesterone dependent upon your DXD stage?
So in this study, which is the only one I'm aware of that looked at this issue, they actually included all stages of endo. So some of them were severe, some of them were really mild. So we don't know the answer to that question. I would think in theory that the answer would be yes. If it's more severe, you probably need more progesterone, but we don't know that. Yeah. Very, very interesting question, but nobody knows yet. I'm hoping somebody will, once this is published, I'm hoping someone will take it and run with it and get the answer for us.
A1C.
Okay.
A1C
Yeah.
is 5.7.
Okay.
I don't have PCOS.
Okay.
Do you still recommend metformin? That's all I got.
It would depend on what your fasting sugar and your fasting insulin are. I don't just use the A1C. Your A1C is a little high. So there's a lot of factors that go into that. I'd need to know your body mass index. I'd need to know how many calories you're taking. I would need to know your genetic history. So yeah, there's a bunch of factors, but I would certainly consider giving you metformin. It's worthy of consideration.
Hi, Dr. Victory.
That's me.
Is it true that funding for IUIs is back?
Funding for IUI never left. We've still got funding for IUI. We just run out of it every year, but we still have some here in Windsor and we have plenty left in Sarnia. So we have funding for IUI if you want funding for IUI. IVF funding is now here as well. So that's the big news.
Does the severity of your DX stage of endo, what?
Diagnosed stage. Yeah.
I feel like I read this before. 1 versus 4 meaning you need even more lower stage of progesterone.
You read basically that.
Yeah.
Different person maybe, but.
Good, yeah. Happy Tuesday, Dr. VNT.
Happy Tuesday.
How long does it take sperm to recover after quitting drinking and vaping? Do you recommend both the vitamin and supplement formulas by YAD?
So we like the YAD product. I'm not picky about which vitamin brand you use. The YAD products are good products. So they're Fertile Pro. And then the other one that's also really good is Pro Fertile, which has Health Canada approval. So both of those are great products. No problem with using those. In terms of how long, it takes 3 months to fully recover your sperm. You will see changes after a month, but you won't see full changes for 3.
39.
Okay.
2 to 4 weeks after retrieval with 6 by 6 centimeters area on right ovary. RE says maybe hematoma clot, cyst. How common? Impact, next stims, timing, and some tips.
Wow.
Yeah.
Okay. So
no warning.
I'd need a picture in order to be able to tell you what I think it is. It certainly could be a hemorrhage into the cyst. So that'll take a couple of months to settle down if it's that big, maybe a month, 6 weeks. Impact, it won't have any other than pain and making intercourse uncomfortable. But if it's that big, it has the risk of torting your ovaries. So don't do anything where you're jumping up and down or heavy straining, lifting exercise. And then in terms of how long to wait, I don't know, 2-3 months, I would think, for that to settle down before you try to get pregnant. The only big question I would have is there a chance that it's an endometrioma? If it's an endometrioma, that's a whole other issue because that's a big endometrioma. You would need that dealt with. So if it shrinks, it's not an endometrioma because endometriomas never shrink. If it doesn't shrink and it stays there persistently, then you got to consider that it might be an endometrioma.
Hello, T and Dr. B. You guys rock.
Thank you.
So it's a group rock right there.
It's a group rock. Yep.
Question.
Yep.
I'm banking embryos and want 2 to 3 kids.
Okay.
Leaning towards 3, hopefully.
Okay.
How many embryos should I bank before I start transferring?
Well, that depends on your age and how many PGT normal embryos you have. So it'd be very difficult to answer without knowing the number of genetically normal embryos. You should watch Embryo Math, our video on YouTube, which explains how to figure out how many times you need to do IVF and how many embryos you need. But I'll give you the short version of this. Richard Scott has a research paper where they demonstrated that you have a 95.2% chance with 3 genetically normal embryos of achieving 1 live birth. It goes up as high as about 98% if you have 4 genetically normal embryos. Now, that's not to say that everybody's going to need to use 4 genetically normal to achieve it. But if you have 4, you have up to a 98% chance. You might get it on the first try, and most people would. But if you don't get it on the first try and you need a second or third or fourth, by the time you go through 4 embryos, you got a 98% chance. So for you to figure out how many you need, if you want 3 kids, I would say minimum you need 6 to 8 genetically normal embryos if you're going to try for 3 kids. Again, you might get 1, 2, 3 lucky each time and it worked, but it may not work that easily. And so if you at least double or triple some of those, you're looking at somewhere around 6 to 8 embryos. That would be a reasonable guess. So how many cycles will you need to get to that? So there's an attrition rate, right? So remember that you're going to have, these are euploid embryos on day 5 or day 6. So if we take 6 and you're an average, let's say 35-year-old woman, we know that half your embryos will be normal at 35. So that means you need 12 embryos on day 5 or day 6 in order to get 6 that are normal. So in order for you to get 12 embryos on day 5 or day 6, you probably need a good 20 fertilized eggs. And in order to get 20 fertilized, depending on your lab, you need somewhere like 20 to 26, maybe even more if they're not a great lab, 28. So anticipate needing somewhere between 20 to 28 eggs if you're 35. The older you are, the higher that number gets. The younger you are, the lower that number gets.
What is the chance of success with a PGTA healthy embryo and a 30-year-old female suffer from PCOS and recurrent loss?
With us, if your body mass index is reasonable, very high. Now, I would need to know why you have recurrent loss. We wouldn't transfer into you till I knew. So it's hard for me to gauge that without knowing more about you. But, you know, a 30-year-old with a PGT tested normal embryo, I mean, we'd be getting an 80% success rate or higher. But recurrent loss changes that, right? So we need to know what's wrong.
Hi, Dr. BNT. My husband and I have both female and male factor infertility.
Okay.
We're interested in embryo adoption, but it seems like both clinics we contacted, VRC and Create, do not have any donated embryos. Will we be able to receive a donor egg and sperm and make our own embryo through VRC?
Absolutely. You can get donor eggs, and it's very easy to get donor sperm. So we can make embryos from a donated source for both. That's very simple to do. We do have some donated embryos. We just don't have a lot. But yeah, we can provide you with all sorts of different options. So just ask for a referral and talk to me personally, and then I'll tell you what your options are, and we can give you the list of what's available, and we go from there.
Hi, Dr. BNT. Can untreated Crohn's disease cause poor egg quality? And if so, can it be improved with treatment? I haven't been able to produce good quality embryos, and I was just diagnosed. I'm 28.
So I'm sorry you're going through that. Crohn's is a really hard disease, so my heart goes out to you. So uncontrolled Crohn's causes an enormous amount of inflammation. It is known to be detrimental for fertility for a variety of reasons. From the inflammatory perspective, from the egg quality perspective, there's an autoimmune component, obviously. And then on top of that, there's a physical component because Crohn's often causes tons of inflammation in your pelvis, and that inflammation can affect the fallopian tube. So yes, it does have a very significant impact. And the meds that they use to control Crohn's can actually have a very beneficial effect on patients trying to get pregnant. So you may find it's easier once you've treated your Crohn's disease.
Doing FET as follows. You ready? CD21.
Cycle day 21.
Start Lupron and prednisone. overlap 0.2 mils E2V, add Neupogen, aspirin, HGH. We'll do IU PRP 2 times and intralipid infusion. Last cysto showed healthy
Trilaminar.
lining,
Trilaminar.
lining,
Yeah.
just 5 millimeters thin. Continued, what are your thoughts on this protocol? Oh, by the way, what up, T? And hi, Dr. V. I wish every RE doctor was like you.
Oh, thank you. That's very sweet. I wish every RE doctor was much better than me. I like the protocol. I don't love the fact that they're giving you estrogen. We use letrozole. Everything else about what you said is okay. Most centers do not use steroids until closer to the embryo transfer. So I'm not sure what the value of using it in you is, but it's case by case. And if you have reproductive immunology issues, which it sounds like you do because they're giving you a bunch of other stuff that suggests that, then that's a different story. You may need a longer exposure to the steroids to suppress whatever's going on. The problem with it is it may be suppressing your response from the lining thickness, and so that could be part of the problem. I don't have a problem with you continuing. I, again, would use letrozole instead of estrogen. You're still on a conventional replacement. PRP is awesome. It works really well. There is some interesting references out there in the public amongst the fertility specialists that the PRP benefit doesn't actually show up until the next month. So that if you use it this month, it's actually next month when you see your lining thicken. So that's something to think about as well.
After reading this study,
Yep.
will you now up the progesterone dose in endo patients?
I will. I definitely will. Yep.
I had 78 eggs retrieved.
78?
Yep.
Oh my God. That's insane. I've never heard that many before.
30 fertilized.
Okay.
At day 3. And only 11 embryos on day 7.
Yeah. On day 7?
Is there any way of knowing why the drop off?
Yeah.
I do have PCOS.
Yeah. Yeah, there's a very easy way to know. You had 78 eggs retrieved. Your estrogen levels would be so high, none of those eggs would be healthy. So that's insane. Like, you can't retrieve 78 eggs. That's crazy. And they probably stimmed you for way too long. So you are probably someone that needs a little bit of a higher dose at the beginning to kind of push the eggs to grow. And then you need to drop the dose down as you get closer to the end. You should not go more than 11 or 12 days of stim. It's much better to get 10 good quality eggs than it is to get 78 not so good quality. And then there are other factors, especially if you're PCO. If your body mass index is high, it's a big problem. It very negatively affects egg quality, embryo quality, blastocyst development, implantation potential, all of those things. But there's no one that should be retrieving 78. We don't even do that to our egg donors when we've got a homosexual male couple and we need enough eggs for 2 sperm sources. I still don't aim for 78 eggs. That's insane. I can't imagine why they would do that to you. You should come and see us.
That's it.
I've never heard. In all the years we've been doing this show, can you remember anyone ever telling us they got 78 eggs?
It sounded like a lot.
I've literally never heard of that before. That's crazy.
Hi, T and Dr. V.
Yeah, thanks for downplaying me there.
You even have more exclamation marks there.
It's good I keep Kleenex nearby for the tears at the end of this show.
I had my CD12 ultrasound.
Okay.
This AM for my IUI cycle.
Okay.
I had one follicle that was 22 millimeters. Lining was 10.5 millimeters. Are those ideal? Trigger 10 p.m. tonight, IUI Thursday AM? Thank you.
Yeah, those are pretty good. We sometimes go even a little bit earlier. There was a study recently that said 19 to 21 is the optimal time for trigger. But we actually saw a decrease in our success rates when we moved from what we were traditionally doing, which was more like 18 to 20. So we try and aim for a little bit earlier, but it depends. So every case is different. You got to factor in the endometrial lining. Maybe there's another egg which was like a 14 the day before, and you might get 2. So, we play each case individually, but we would probably trigger you a little bit before at 22.
Hi, Dr. Green Tea.
That's us.
Mm-hmm.
Yeah.
For the letrozole cycle, why do we only take letrozole for 5 days instead of all the days of stimulation? Thank you for all your super kindness and good heart.
If you're referring to during IVF, it can actually be done either way. You can take it for just the 5 if you're trying to boost the response. If you're trying to suppress the effect of the high estrogen levels, you take it the whole time. So it depends on what the case is. Like in a PCO patient, you want to take it the whole time. But in someone that's got weaker ovaries, DOR, you only want to take it for the 5 days.
Dr. B, can you draw us a recommended injection site rotation for microdose Lupron flare since it's 4 shots a day?
It's 2 shots a day.
I got 4 shots.
It's just 2 shots a day. So do 1 on one side and 1 on the other. Anywhere in your body that's got fat, you don't need 4 shots a day. I mean, I can draw it for you, but just anywhere on your body where you've got some fat, 1 on one side, 1 on the other. And it's just 2 shots a day. I don't know why you're doing 4. Microdose Lupron just should be 2 shots a day.
Hi, Dr. VT. Exclamation.
Excellent. The exclamation mark was for the T.
Yeah.
I wasn't.
Yeah, definitely not for the D. Definitely.
All right.
40 with DOR.
Okay.
2 healthy kids at home.
Yeah.
1 mini cycle gave an euploid that failed in FET.
Okay.
Got pregnant naturally and miscarried at 7 weeks.
Oh, sorry.
Would you recommend PGTA?
Yes, I would. I would definitely recommend PGTA. In Denmark at this meeting I was at, there was a great debate between 2 super intelligent people. So one guy was from Europe and said, we absolutely should be abandoning PGT because there is not a single valid study to demonstrate that it is beneficial. And he's right. There really is not good evidence to show that it is beneficial. However, following him was Richard Scott, who I have tremendous respect for because he's literally the smartest guy in the world. Like, he is so intelligent, it's scary. And Richard Scott got up there and presented data, some of his own and some from other centers and so on, where he very convincingly said, if you're over 32, and his threshold is 32, everybody should get PGT because it's actually more cost effective to do PGT at that age. Now, that's in an American model where the costs are crazy high. In a Canadian European model, it'll change that dynamic. So the age threshold might go up a lot, but there is a point at which it makes sense. And that age is probably around 37, 38 for us, which is when we start recommending it. There was a recent study we reviewed on the show, which said that if you have less than 3 embryos, don't do the PGT. It was from Dr. Casper and Paul Chang, who was my junior resident, and actually he was with us in Denmark. So if you're watching, Paul, hello. The problem with that study is that literally the week after they pre-published that study, they pre-published another one in the same journal showing the exact opposite result, literally the opposite result. So I don't think anybody knows what to do yet. So I'm still going to support doing it for our patients that are over 37, 38. If they want to do it, we will. If they don't want to do it, we won't. But I think it's worth doing in that age group because you are going to have a lot of aneuploid embryos. And the key is not to find the ones that are normal. The key is to eliminate the ones that are abnormal because you're wasting time and money putting those in. No one is proposing that putting in aneuploid embryos, and this is really important for everybody to remember, will result in a positive outcome. There is one reported case where in the Barad study, which we reviewed on the show, they put in a genetically abnormal embryo and the patient actually had a normal offspring from it. In all of the other ones that they put in where the embryo was abnormal, it actually didn't result in anything. So mosaic embryos are different. 50% will stick and become normal. But that's not the same thing as an aneuploid embryo. And so if the embryo is truly known to be genetically abnormal, you probably need more embryos. It's unlikely those ones are going to work.
Dr. Vinci, looking for clarification about delayed ovulation after egg retrieval. We completed an egg retrieval in August. I had a fake cycle 8 days after, but I'm currently on CD33 and still haven't ovulated while awaiting my next. I know delayed ovulation is normal as our bodies attempt to regulate hormonally, but is this much of a delay normal?
I would go get checked out, make sure you're not pregnant, make sure there's no cyst left over. And so you need an ultrasound and some blood work. It's not normal to have that much of a delay, no.
If someone is on 3-month Lupron Depot and wanted to do a transfer earlier before 3 months is up, how would that work?
You'd probably need estrogen to get your body to respond. Or you could try letrozole. I don't know if it would work in the middle of suppression from Lupron Depot, but it's worth a try. Otherwise, you would need estrogen. You just give the patient estrogen and their lining will start to develop. I don't recommend that if you're on 3-month Lupron Depot, because you either have fibroids or endometriosis or adenomyosis, all three of which are estrogen based. But if you have to, for some reason, move up your timing, that's the main way to do it. So I would try a 5-day course of letrozole first. If it works, hallelujah. If it doesn't work and you have to, you don't have a choice but to turn to estrogen.
Hi, Dr. VNT. What are the risk benefits of a double embryo transfer? Should both embryos be of equal quality?
They don't have to be of equal quality. The risks, well, the benefits, higher success rate, higher pregnancy rate. The disadvantage, okay, so if you get twins, and that's an if, but if you end up with a twin pregnancy, there are maternal, fetal, and social risks. So the maternal risks, high blood pressure, preeclampsia, diabetes, excessive weight gain, skin stretching, pain everywhere your joints are back, blood clots, need for hospitalization, need for interventions like cerclages and surgeries and all of this stuff. Much higher risk that you could be bedridden, hospitalized, need for cesarean section. It goes on and on and on. Preterm labor episodes and so on. For the babies, the main problem is that they come out early. So if your babies are delivered early, literally every single risk you can imagine for a child goes up. Blindness, deafness, feeding difficulties, temperature control, interventricular hemorrhage or intraventricular hemorrhage, cerebral palsy, God forbid, mortality, death, all sorts of problems increase, respiratory difficulties, which is the big one, learning disabilities later on in life. So big issue for the kids. And then the social part, it's an 80% divorce rate. So we do not recommend putting in two embryos almost ever. We do it on occasion when my arm is being twisted, but we try very hard to avoid doing that. It's an endless series of questions.
9 o'clock.
It is 9 o'clock.
Yeah, that's what it is, but I don't think they know.
All right.
So I'm going to read one that I thought was pretty good.
Okay.
Hey, Dr. T and Student T.
Dr. T and Student T.
Yeah. It's just all me right now. I figured, how could I not ask that one?
I'm walking off. That's it. I'm out. Yeah.
They're having a good time with this, that's for sure. Is this video going to be said? I had messaged a question, but I'm late to the live, so maybe you answered it. But I don't know.
What was the question? Oh, we don't know?
Yeah, they must have asked it. And they
Did you ask all the ones we got ahead of time on Instagram? Were they on here?
Oh no, that's not even.
We haven't even touched those? Oh my God. That's like there's a ton of those. I got to go through those. All right. Yep. Fire away.
Wow.
We're going to need to do another.
This is a super interesting paper.
Yeah.
Thank you. Good learning, even for us that we don't have endo.
Yeah. Yep.
What would be the recommended dose for a severe endo patient based on this study per day?
So we would use vaginal progesterone, crinone, endometrium, or permetrium. So crinone's twice a day, endometrium's 3 times a day, permetrium we use 200 3 times a day. Your injectable, we normally run our patients at 50. So for 50 milligrams per day, that gets us in the right range. So for this, I'd probably go up to either 100 or 75 and see where the patient is at after 3 days of use.
What about besties?
What about
I
besties?
think because you said you can't have favorites. So.
Oh, can we have besties? We cannot have besties. We got to keep it professional. And I never tell my patients that they're my favorites. I may have favorites, but I don't say that to the patients. We got to be squeaky clean as physicians. So, yeah.
You are my favorite doctor.
Oh,
mine as well. But
yeah.
That's something else.
Thank you.
Yeah, you're welcome.
You know, that means a lot to me because I had favorite doctors as I was a resident. I still do. It's the same guy. He was amazing. Best teacher, best surgeon, best human being I know. So to be somebody else's favorite means a lot. That's pretty cool.
For IVF,
yeah.
How much better is using fresh sperm than sperm that has been frozen for about 6 months?
30%.
Straightforward.
Yeah, that was an easy one.
What is prolactin important for?
Endometrium, estrogen levels, breast milk, some of the dopaminergic cells in your brain, which control movement and Parkinsonian movements and things like that. Probably 100,000 other things that we still don't know about, but those are the main ones.
Is the wait list for all patients 1 year?
No, but it's pretty close to that.
What is a fully funded cycle?
What is a fully funded cycle? It's an IVF cycle or sperm freezing or egg freezing, whichever one you need. It includes everything except the medications, the storage fees, and genetic testing if you need or want the genetic testing.
Thoughts on fresh transfer for those with endo?
If you're doing natural cycle IVF, it's totally fine. If you're not doing natural cycle IVF, there is nothing in the world that will ever convince me that it makes any biological sense whatsoever to take someone who you just took estrogen, which is endometriosis fuel, and just poured it all over the place by jacking up their estrogen levels and then going to try and do an embryo transfer. You are literally at your most inflamed point when you are trying to get an embryo to stick. It makes zero biological sense to me. So I would never do a fresh transfer with an endo patient unless they were doing natural cycle IVF where they made one egg, you went in, you retrieved it, you turned it into an embryo, you're putting it right back in.
Can you explain your typical transfer protocol for a patient with endo, modified natural with letrozole? How much endometriosis and PIO?
So we wouldn't change our protocol because our main protocol is very endometriosis friendly and supportive, but there are some tweaks. So first of all, if they have endo, 3 months of Lupron and letrozole first, extend the letrozole for 5 days past the 3 months. Don't take any estrogen unless you absolutely need to. If you do, the smallest dose possible, like 1 or 2 milligrams of estrase, either oral or vaginal, that doesn't make a big difference. Wait till the lining gets to 8 millimeters. Start vaginal and injectable progesterone. As I just mentioned, reasonable doses of vaginal. The PIO, I would probably start at 75 or even go up to 100. Melatonin, resveratrol, NAC, coenzyme Q10, curcumin, those will all help you with your endo as well. We may consider surgery ahead of time before we start any of this stuff, and then just do a really good embryo transfer. If because of your endo, your uterus is upside down, you cannot see that properly on an ultrasound. So you need a transvaginal guided embryo transfer. There are very few of us that know how to do that. Is it still endless? Do we have to? It's a big show.
It's a big show.
Should we? What are we calling it? It's 9:06. 4 more minutes, 9:10?
9:10.
9:10. All right. See what you can squeeze in. To all those of you that asked your advanced questions on Instagram, I will come up with a whole series of little mini answers like I've done before and answer them. Yeah.
What does research show for using calcium
Ionophore.
yeah, to help with fertilization?
So the majority of studies suggest that it is beneficial, and so we use it. If someone's had previous failures, previous bad outcomes, not any blastocyst development, we do use that technique to improve our outcomes.
Can exposure to HPV affect your fertility? I do have my HPV vaccine, but my partner had an infection in the past.
Not that we're aware of. Nobody knows that causes anything, and it has been looked at.
Thank you so much, Dr. Victory Hart. Even though I'm in Calgary, every hard decision has been consulted for free on live session. Thank you for your time and what you have done for us.
Well, good luck in Calgary, but you can come here even if you're in Calgary. We provide care to patients in Calgary all the time.
Can you over suppress, which can cause a failed FET?
I mean, you can over suppress so that the lining doesn't develop, yes, but if your lining develops, you can't over suppress.
78? That can't be right. That's going back to the embryos.
That's psycho.
That's a comment.
I've heard of those super high cases. In fact, one of my egg donors who just contacted us to help her out had 62 recently at another clinic. So yeah, those kinds of numbers, you're gonna have terrible egg quality. Terrible.
What's up, T&V?
What's up?
Currently, CD13 took Medicare 75 since day 3.
Okay.
10-day US no follicle growth. Today, BW showed a drop in estrogen double times dose to 150. Do I still have a chance?
No, you're wasting your money. Stop. Definitely stop. Cycle day 13, you should be ready for trigger a day or two ago. Don't waste any more money. Stop. You need a new cycle.
Could an ovarian cyst be the cause of elevated estrogen, and could this cause the chemical pregnancy I had last month?
I can't answer the second part of that, but it could definitely increase your estrogen levels. Yes. There's no way to know if it could have caused the chemical pregnancy.
What is the wait time for IVF out of pocket at your clinic?
Just enough time to get you tested and get you ready. So sometimes that's a couple of weeks. Sometimes a little bit longer, depends on what's needed. But usually if we see you now, we can have you ready within a month.
Trying to understand this. Are you saying it's a year wait to do a IVC with your clinic?
It's a year wait if you want a government-funded IVF. Yes. Yeah, because we had a long lineup before because the area didn't have anybody. And so people were on our wait list and we were getting cycles from the other communities. So it was tough.
Last one.
Yeah.
Exactly 9:10.
Okay.
Why would my period come 10 days after ovulation? Could it be not enough progesterone and or thin lining?
Yes. Infection, thin lining, not enough progesterone, stress, problem with egg quality, problem with hormones. There's a lot of different possibilities.
Okay.
Done. Do you want to screenshot the others just so we do justice to everybody?
Yeah, I will.
It'll shut off though before you have to screenshot on that.
I'll get it. The
Can you?
Instagram will stay. Yeah, Instagram will stay. And I got the Facebook, YouTube right here.
You got it? All right, you start screenshotting. Okay, so listen, thank you all for watching. We appreciate so many viewers. Apparently it was a big show. I don't know, because I'm just staring at a good old-fashioned Canon camera. So have a great week. I hope you guys are safe and fertile. And we will be back again next Tuesday. Yeah, because next Monday is Thanksgiving. And stay tuned, because we are actually going to have a House of the Dragon OBGYN video prepared for you guys, because I love House of the Dragon and we're going to try something new. So we are going to review the obstetrical cases on House of the Dragon. So hopefully you guys will enjoy that if you're also viewers. And let us know how you feel about our other stuff. I've been doing a lot of reels Some of them have struck gold and some of them have not. So let us know how we can do things better. We're always open to suggestions. I wish you all a very good night. Make sure your fertility center is doing the right stuff for you. Don't accept cookie cutter medicine.